Good morning, ladies and gentlemen, and welcome to our webinar at MAHSA University. Now, this is a special webinar that we have organized in conjunction with the World Antimicrobial Awareness Week, which is basically on the 18th to the 24th of November 2020. And the theme for this year is basically handle antibiotics with care. Now, the topic of our webinar is an interesting one because it involves all aspects of health, human health, animal health, and the environment at large. And never before the importance of the usage and the proper usage of antimicrobials has become more vital than what we are experiencing nowadays during the COVID-19 pandemic. The COVID-19 pandemic basically had a huge impact on the usage of antimicrobials, and this is why we are discussing it here. So my name is Dr. Saad Musbah. I'm a senior lecturer at the Faculty of Medicine, Bioscience, and Nursing, and I'm also the head of Student Central at MAHSA University. Welcome, ladies and gentlemen, to our webinar entitled Antimicrobial Resistance Beyond the COVID-19 Pandemic. Now, for this webinar, we have two special guests. I would like to introduce them, and they are actually experts in the field of clinical microbiology, infectious diseases, infection control, and of course, antimicrobial resistance. And for that, allow me to introduce the first speaker for our webinar, Professor Dr. Mahmoud Shurman. Professor Dr. Mahmoud Shurman, he's the Chief Infectious Disease Section at the University of Tennessee Medical Center. Professor Shurman, basically, he's a specialist. He has a master's in healthcare administration, and he's currently the infectious disease specialist, chief at the University of Tennessee Medical Center. He's actually an American board certified internal medicine, infectious diseases, and infection control specialist. He has over 50 peer-reviewed publications and book chapters, and he's a member of the American Medical Association and was a speaker at many international conferences on infectious diseases and infection control. Welcome, Professor Dr. Shurman. How are you?
Thank you, Dr. Saad. I appreciate it. Thank you for the kind introduction. Good morning, everybody.
Good morning. It's a pleasure to have you, really, Prof. And our second speaker is Dr. Ghulam Dab'an. He is a research scientist at Mount Sinai Hospital University Health Network in Toronto, Canada. Dr. Ghulam, he obtained his PhD from University of Malaya in medical microbiology, and he works as a research scientist in Mount Sinai, and he specializes in developing and applying novel diagnostic techniques in the detection of various infectious diseases. Most recently, he's been actually busy working, developing novel diagnostic assays using droplet digital PCR technology to identify fungal infections directly from clinical specimens. And of course, he's also specializing in antimicrobial resistance, particularly among gram-negative bacteria. Welcome, Dr. Ghulam. How are you, my friend?
Oh, thank you, Sarah. Thank you very much, my friend. It's been a long time ago since Malaysia. Yeah, yes. It's my pleasure to be here. Thank you so much.
Yes, welcome. Before we start, I just need to mention that both Professor Mahmoud Shurman and Dr. Ghulam Dab'an, they are dear friends and colleagues and co-workers. In fact, Professor Shurman, he was actually the supervisor of both myself and Dr. Ghulam during our masters in Jordan. So it's really a pleasure to have you, Prof, here, and I would consider this as our reunion, really, after 15 years.
I'm very proud of what you both achieved. Very proud.
Yes.
Yeah, thank you so much.
Thank you very much, Prof. It's a pleasure to meet both of you. So just to start with, let me just give a brief intro on the topic itself. Antimicrobial resistance. We all know that many bacteria have become resistant to a variety of microbes. Of course, this has many factors, but the main factor is, of course, the misuse of antimicrobials. So this is where clinicians and infectious disease specialists, they play a very important role in optimizing the usage of microbes. But what makes this topic more special is actually because we are living in the COVID-19 pandemic, and we all have seen that the number of mortalities and the fatalities has drastically increased for the past few months. Of course, this is due to the infection by the coronavirus itself. But what many people don't know is that many of these fatalities are due to secondary bacterial infections that were caused by drug-resistant bugs. So this is why we want to emphasize the topic of this webinar today. And we will start with our first speaker, Professor Mahmoud Sherman, and he will be talking to us about the explanation on why the phenomena of antimicrobial resistance is happening, and what are the optimal antimicrobial dosages that are recommended, and later on how we can actually prevent the emergence of AMR. Professor Sherman.
Thank you, Saad. Thank you.
Yes.
Yeah, I'm going to be talking about the antimicrobial stewardship in the time of COVID-19 pandemic. The outline of the talk will first try to recognize the impact of the antimicrobial resistance. We'll try to identify the practices associated with increased resistant risk. And as Dr. Saad just alluded to, we'll try to focus on the antibiotic prescribing habits of doctors and antibiotic utilization in hospitals. I'll try to touch base on something very important is, do we have new antibiotics on the horizon? Should we expect the cavalry coming and rescuing us from the problem of resistance that we're facing worldwide? Then I'll move after a break and talk about the COVID-19 pandemic and its direct impact on the antimicrobial resistance. And obviously, this is a new thing since we only had COVID-19 since December. This topic needs a lot of emphasis because we are learning as we go. And I will conclude with steps towards decreasing the resistance, focusing on establishing stewardship programs. When we talk about antibiotics, next slide, please. When we talk about the antibiotics, we talk about agents that save lives. If we look at this table describing the difference in mortality for common infections before the antibiotic era and after the antibiotic era, we can see significant importance in preventing mortality up to 100% in certain infections. If we talk about something like endocarditis, the mortality rate was up to 100% before antibiotics were described and used in health and medical field. Now, fortunately, that mortality rate is reduced to almost 25%. And the same for pneumonia, the same for meningitis. These are life-threatening infections. We can clearly see an impact on changing in mortality just because of the antibiotics. If we compare this to the effect of something like treatment for myocardial infarction, which is a devastating thing that any patient can withstand, if you use something like streptokinase, the change in mortality was only 3%. So we are talking about magic bullets here, something that really impacts somebody's living and affect their morbidity and mortality. And that's why it's very important that we preserve them so we can use them when we need them for the patients who are at most risk. The problem with resistance is not new. It's been addressed for many years now. in the United States, the Infectious Disease Society of America tried to address that as early as 2004, when at that time they were having a campaign about bad bugs, no drugs, and there was issues with antimicrobial development and research. And that campaign was focusing on trying to push pharmaceutical companies into involving or relocating some of the resources to invest in developing new antibiotics. 5 years from that, in 2009, unfortunately, it wasn't much different. And at that time, they started using the acronym ESCAPE, which is basically the first letter of the problem bug at that time, the Enterococcus, the VRE, the Staph, the MRSA, Klebsiella, Acinetobacter, Pseudomonas, Enterobacter. These were the problem bugs that were affecting patients' lives because of the multi-drug resistance and lacking some of the important antibiotics to tackle these serious infections. And when we talk about resistance, we can see from this slide it's worldwide, but it is important to know where you're practicing, because common bugs have different resistant patterns depending where the doctor is, where the patient is. And if we look at an E. coli resistance, for instance, and we are talking here about blood isolates only, you can see like in India, the resistance is way worse than other places in the world, especially when we talk about third generation cephalosporin, the blue bar there, where it is a real problem in certain parts of the world compared to others. Whereas if we talk about, next slide please, something like Klebsiella, again, it's more common to find resistance with that in certain part of the world compared to like UK or Australia or United States, where they don't see a lot of extended spectrum beta-lactamase producers, ESPLs, or carbapenem resistant microbacterium. Like this is one of the differences that we need to develop, like an antibiogram for each hospital, so doctors there, nurses there, providers can understand what to expect when a patient is having certain bugs. Next slide, please. When we talk about Staph aureus, we see some changes there. It's more common to have MRSA, methicillin-resistant Staph aureus, in the United States compared to UK or South Africa or Australia. And again, it just establishes what we are trying to advocate here, developing local antibiograms to help guide best antibiotic prescribing habits. So what is this problem that we're seeing with the resistance? Is it just us exposing the bacteria to an antibiotic and they develop resistance? Or is it something that the bugs had for many years and it's like a switch, they switch it on when the antibiotic is introduced? To test this theory, scientists from Canada got hold of 30,000-year-old permafrost sediments in northwestern Canada, and they wanted to test for bacterial DNA, and they wanted to see what kind of resistant genes they can isolate. This is way before we know antibiotics as we use them now. This was before we developed any type of antibiotics. So what did the research say? It showed that the analysis of the DNA of the bacteria showed many resistant genes that we are seeing now in many of the pathogens that we have. And I think Ghulam will talk more about the resistant genes, so I'm not going to spend a lot of time, but something like VAN-A was almost identical in function and structure to the stuff that we see now, encoding for VRE, the vancomycin-resistant Enterococcus, and the vancomycin-resistant Staph aureus. So all these resistant genes are embedded in the DNA of bacteria for thousands of years before even antibiotics was introduced. And that, in fact, can explain why development of resistance sometimes can happen even during research and development in the early stages. Once you have the antibiotic in the first stages of the research, you start seeing resistance to that just because most likely the bacteria we are testing have a a resistant gene somewhere, and it's just turned on. And when we talk about resistance, obviously, we just showed that the bacteria already have genes to code for that, but unfortunately, we are not helping also. If we look here at this graph at the high drivers of resistance, we can see that the human misuse or overuse of antibiotic is one of the commonest drivers of resistance, and that's because of using antibiotics over the counter, using antibiotics like without getting cultures, and we'll talk more about that, using antibiotics that is not needed for prophylaxis or prevention. And unfortunately, this is something that we are trying to focus on in developing any stewardship program. The other one is the misuse or overuse of antibiotic in agriculture and animal care. And unfortunately, there's many countries who are using antibiotics in agriculture, and that can create resistance for the whole community. Environmental contamination, healthcare transmission, suboptimal use of diagnostics, especially the focus on rapid diagnostics, which Ghulam will talk a little bit about. All these things also are drivers of resistance. So we need to focus on the most important ones, the ones that have high driver of resistant risk, and we can kind of control are the human antimicrobial use, and that's be the focus of our presentation today. So when we talk about antibiotic optimization, it's a balance. There's needs of the patient and the society, because we know that if we use inappropriate antibiotics, that usually carries high mortality. We showed that in the first slide. What happens if we don't use appropriate antibiotic and mortality? The drawback of indiscriminate use of the antibiotics, especially the broad spectrum ones, will drive resistance. So it's always this balance that everybody needs to be attentive to every time we use antimicrobials in healthcare settings. And when we talk about antibiotics, we need to remember that it's true that we have resistance. Unfortunately, it's on the rise. Unfortunately, we are not seeing a surge in the antibiotics in the pipeline. I'm going to show you this graph, which shows the number of approvals of antibiotics over the years. And if you see between the 83 to 87, can we go back, please? We had up to 16 antimicrobial agents approved in one of the columns there. If we look at the 2008 to 2012, we only had 2. And because of that, governments were working on getting more antibiotics in the pipelines. They were trying to, can you go next, please? They were trying to push the companies to produce more antibiotics. And because of the government funding and the government regulations, in the last 2 years, we had up to 41 antibiotics in the pipelines, which is a huge surge compared to the previous 30 years, which is very exciting, but I'll show you why we shouldn't be very excited because of what we are going to show. These are some of the initiatives that governments had. Some were led by WHO, some were led by local governments, and some of these were directly sponsoring research and development of antibiotics, especially the need ones for certain resistant pathogens. Next, please. So this is why we shouldn't get very excited about all these new antibiotics. This slide showed some of the antibiotic at the time of the slide. They were in the pipelines. Most of these made it to the market. These are designed to treat gram-negatives, E. coli, Pseudomonas, Acinetobacter, and you can see there's a lot of holes in the coverage to begin with. But the most important thing is the mechanism of action. If we have resistance already, are we bringing new antibiotics to the market that will go around and overcome that resistance? And unfortunately, for the majority of these medicines, they were similar mechanism of action to the ones that we already have issues with resistance. Why they made them, one might ask. Some of those can be given like once compared to 3 or 4 times a day for the same comparators. Some will have better like a profile from side effect point of view. So there is obviously merit to having these in your antibiotic formulary in the hospital, but we shouldn't be expecting magic just because a new antibiotic was produced for gram-negative. Can you go next, please? The next slide will show the gram-positive, and the same story there. Some of these are already in the market. Some can be given once a week. Some can be given once a day. They may not have the vancomycin toxicity, especially nephrotoxicity, but with the exception of telavancin, they have the same mechanism of action as vancomycin, so the resistance will be the same. The telavancin can affect the cell wall and the cell membrane, and that's why that combined mechanism of action can overcome some of the resistance. So we are expecting so many of these, but unfortunately nothing much can be expected, or not a lot can be expected from the front of overcoming some of the resistant pathogens, especially Pseudomonas and Acinetobacter. And one can wonder, and this is important slide that I like to share, is like, why they don't make more? Antibiotics makes money. A lot of money can be generated from single antibiotic. And this slide on the left, if we look at the sales from recently launched antibiotics, if we talk about Avicage, which is the ceftazidime, avibactam, ceftaroline, the second one, Zerbaxa, which is the one that we use a lot, ceftalozane. So there's so many newer antibiotics on the left. If we look at how much money they generated in the first year, which is the black bar, it is in the teens, like $10 million, $15 million. In 2 years, maybe the first couple of them can exceed $60, $70 million. If you take one of those antibiotic and put them in the sales of other products, you can see that Telfaro, the ceftaroline, is way in the bottom compared to diabetes medications, compared to neuropathy medications, like COPD medications. And the difference in the sale is not only that direct cost of the antibiotic, is the duration. Most antibiotic can be used for like a week, 2 weeks. All of the medications on the right side are used lifelong. So it's more profitable for the companies, pharmaceutical companies, to invest in a diabetes medicine or a high blood pressure medicine compared to the antibiotic, with risking getting resistance, with risking the cost to develop one. Then they cannot make the money that they are expecting. Next, please. So we talked about the balance of giving the antibiotic, and before we move to the next section of our presentation, this is very important slide showing that using the right antibiotic from the get-go can save lives, especially in patients who are in ICU settings, patients who are having severe sepsis. These are multiple studies showing that the gray bars compared to the black bars, comparing initial adequate versus inadequate therapy, and the effective mortality almost doubling in some of those studies. So you need to identify patients with infections early, and that's where rapid diagnostics are helpful, and Ghulam will touch base on that. And you need to start the appropriate antibiotics as soon as you can, because it can save somebody's life. And I think we'll have the first stop here for questions and comments. Saad, you're muted.
So what we are trying to say here is that developing new antibiotics is, for pharmaceutical companies at least, is not as, let's say, profitable as developing other types of drugs, like for diabetes and so on. And that puts us in a difficult situation where we have to manage whatever we have, actually. Properly managed through, of course, antibiotic stewardship programs, which you will touch upon. So that means, Prof, what we can take from your slides is that the problem of antimicrobial resistance, or AMR, is as ancient as thousands of years ago. And even with the discovery of the first antibiotics in 1928 by Alexander Fleming, there was actually an acknowledgement that bacteria can be resistant to antibiotics, because it's a natural process, an evolutionary process for bacteria to resist their environment, and of course antibiotics are no exception. Now that brings me to a point that I want to ask Dr. Ghulam about. Dr. Ghulam, you might know that there's actually a global action plan to tackle the growing problem of antimicrobial resistance. And this plan was endorsed in the World Health Assembly back in 2015. One of the key objectives of this plan is actually to improve awareness and understanding of AMR through effective communication, education, and training. And this is why actually the World Antibiotic Awareness Week was established. So my question to you, Dr. Ghulam, is that you work in one of the most prestigious medical centers and hospitals in Canada and probably in the world, which is Mount Sinai Hospital, University Health Network in Toronto. What kind of awareness or initiatives that hospital actually is doing to tackle the AMR problem?
This is a very good question. I think the answer to this question will be a little bit part a technical answer. The other one will be particularly about the antimicrobial or the antibiotic stewardship, and I think Dr. Sharma will talk about this one, because this is one of the things that to tackle antibiotic resistance or the improper way of prescribing antibiotics. But the way in the microbiology lab that as you mentioned, Doctor said that the education is very important. I mean, in addition to the stewardship, the other thing is a very proper diagnostic procedures is very important. I mean, before we're talking about the antibiotic susceptibility testing. So when you have a standard and validated identification procedures, you are doing the first proper thing to identify the causative agent. Once you are once you are sure this is the causative agent, this is the species you are that is causing the infection, then you go forward to the second step by doing the antibiotic susceptibility testing and finding the most potent antibiotics against this bacteria that causing infection. So back to the question, and I think antibiotic stewardship, this is very important. Dr. Sharma will talk about this. The other one is proper diagnosis and then proper identification to the most potent antibiotics. These are very crucial to have a good strategy to combat this kind of problem.
Basically, so I mean, everyone plays a role. That policymakers, clinicians, scientists, even the general public, we all play a role actually to tackle the problem of AMR. And AMR is directly connected to the COVID-19 pandemic. I think Dr. Sharman will be talking in his second part about how the COVID-19 actually accelerated the emergence of AMR in patients. Of course, this is due to secondary bacterial infections, infections that are caused by drug-resistant bugs. And this is a very serious topic that was actually the catalyst for us to organize this webinar. It's a very important and sometimes overlooked topic because many people, they think that the fatalities due to COVID is mainly because of the coronavirus, but actually many of them are actually due to secondary bacterial infections that will exhaust the immune system and makes it unable to fight the coronavirus. So this is where awareness on AMR is very important. And back to you, Prof. Sharman, to talk about the COVID-19 pandemic. What is it, the epidemiology of it, and how is it related to AMR?
Thank you, Dr. So moving about the most important thing that everybody has been dealing with, affected by countries, not only individuals, the COVID-19 pandemic. And I think most countries, and I think Malaysia was no exception, they had lockdowns at one point. And even now they have a lot of social distancing and mask mandates and some restrictions on hospital admissions and hospital procedures. So everybody, in a way or another, was affected by that pandemic. So the SARS-CoV-2 or the COVID-19, it has placed immense strain on the healthcare systems. Doctors, nurses, healthcare workers have been working non-stop to try to combat the effects of this pandemic worldwide. The problem is, as Dr. Saad said, are we just dealing with the virus here? Are we dealing with respiratory co-infection? Do we need concurrent antimicrobial therapy? Unfortunately, due to the lack of enough information, we still don't know a lot about that. We have some data published, and I will share some of them with you. But it is obvious that we've seen this concurrent bacterial or fungal infection with viruses before. Is it the same in the influenza compared to COVID-19? Is it the same compared to the MERS or other coronaviruses? Fortunately, so far, with the data that has been published, it doesn't seem that co-infection with bacterial or fungal is as high as it was with the influenza pandemics or influenza epidemics, which kind of helps us in the next few slides talking about some of the methods of identifying who's at risk of having these co-infections or superinfections, and how we can utilize the antibiotics judiciously so we don't run into more resistant issues. So when we talk about COVID-19, it can by itself cause a respiratory infection similar or indistinguishable sometimes to bacterial infection. You see infiltrates on the chest X-ray, and before everybody was on the lookout for COVID, it was really difficult to identify if this is COVID infection or is there bacterial infection. Obviously, there is some distinctive pattern now for the X-ray. If you talk about COVID, you see ground glass opacities in the middle to lower zones peripherally. Most of the time, when you see that in somebody with the common signs and symptoms that they present with, most of the time that's just the virus causing the pneumonia. Obviously, if the X-ray looks different, if there is like lobar involvement, if there is a cavity, then bacterial or fungal co-infection might be an issue, and that would be one of the ways for early detection. The other one, which Ghulam is going to talk about in detail, which is the rapid detection. We have PCR. We can utilize that for identifying respiratory pathogens. We can use that for blood cultures. We can use that for GI pathogens. We can use that for most common pathogens causing a lot of infections. And despite everything that we have, there's still shortage of data about antibiotic use, indication, and duration, with few described studies that we will share with you in the next few slides. So we are facing some challenges with the COVID-19 related antimicrobial resistance. One of the most important one is resources, because in our hospital, when this started, a lot of resources were redirected toward the pandemic. And I think it was the same case everywhere in the world, where they gave priority, and that kind of diverted the attention from other important AMR surveillance practices that hospitals do. We saw a surge in antibiotic prescribing because we were concerned initially about the co-infection, superinfection. Everybody was getting antibiotics as a standard of care. We ran into shortages of antibiotics. As we showed, the pipeline in the drug development and research is not that strong, it's very lean. And unfortunately, some political things like the US withdrawing from the WHO with all the money that was lost also could have affected and impacted the antimicrobial resistance worldwide. So when we talk about COVID-19 and infection, is there a peculiar thing that causes superinfection with COVID-19 infection? We need to remember something, that since we think most of the patients who are hospitalized mainly present with viral pneumonia, they may not have co-infection or superinfection initially, but if we remember nosocomial infections, we know that majority of patients requiring mechanical ventilation, especially if it's prolonged in ICUs because they are critically ill, independent on any co-infection, they are at risk of higher nosocomial infection risk. So just because of the host exposure history, them being on a ventilator can carry higher risk of co-infection or superinfection. And we know now that COVID infection can cause immune deregulation or dysregulation, and that will affect the bacterial and fungal proliferation, causing patients to be predisposed to those co-infection or superinfection. This graph just describes what we just talked about with increasing interleukins and the anti-inflammatory interleukins, the interleukin 4 and 10, the decrease in the CD4 and CD8 cells, interferon gamma, all these things can cause lung pathology and lung injury and predispose to worsening tissue damage, causing the risk of co-infection with bacterial and viral infection. So talking about data that we have so far, I'm going to share with you some studies that looked at the co-infection part from different parts of the world. This small study with 117 patients came from Ireland, where they included patients with positive COVID-19 PCRs. And of the 117, big percentage, more than 80%, were on antibiotic in that study. And when they looked at the cultures, almost all of them, fortunately, got cultures at the time of starting of the antimicrobials. But if we look at who got actual infection and positive culture of the 84, only 8, less than 10%. And despite that, unfortunately, antibiotics were not stopped, and that caused a lot of strain on the resources in that hospital. If we look at some of the common pathogens isolated from the sputum, is basically what we see in ICU, Pseudomonas, Staph aureus, Klebsiella. And even in the patients who did not have respiratory infections, 7 of the 11 had positive cultures. And again, if we're talking about somebody's infection outside of the lung for COVID-19, you talk about somebody with central line devices. So there is a bigger chance of getting a bloodstream infection. And that's something that physicians need to be on the lookout for. So the conclusion from that study that the rate of bacterial co-infection was low, but despite that, a lot of antibiotic courses were continued and there was no stewardship in that hospital at that point. In a bigger study published from New York City, and that was around the time when the pandemic surge was, I think, around March and April and May, they had 71% of the COVID-19 patients receiving antibiotics, while only 4% of those had true bacterial co-infection. So imagine that percentage. And in that hospital, they did a next step. They looked at their antibiotic resistance compared to the same time the year before the COVID-19, and they saw a 10% increase in resistance to different antibiotics just because of that overuse of antibiotics. The conclusion from that study was the pandemic highlighted the need to close collaboration between stewardship and infection prevention programs, especially to curtail excess antibiotic use and combat the multi-drug resistant pathogens. I'm not sure if you see these slides from the distance, but if we look at this new publication, it's not even out, it's preprint, published in the Clinical Infectious Disease Journal. They were looking at secondary infections. They were noticing a trend towards more sick patients. Again, what we talked about early, patients needing ICU hospitalization, they may have a higher risk of getting co-infection, and those maybe are the ones that we need to focus on when we talk about empiric antimicrobial agents for somebody who's critically ill in the ICU. Next, please. One of the important studies that were published recently is this meta-analysis that tried to include all published data on COVID-19, looking for secondary infection and co-infection of bacteria. Unfortunately, with their methodology, only 24 studies were included because they were trying to look at bigger patient enrollment, like the studies less than 10 were excluded. Next, please. So of those 24 studies, they were looking at two categories. They were looking at co-infections, and they were looking at superinfection or secondary infections. And they noted that only 3.5% of all these studies had co-infection in them, and about 7% had bacterial superinfection. And next, please. When they looked at the site of infection or where the patient was at, they again identified the same finding as the CID journal. Patients in the ICU settings, critically ill patients, are at higher risk of getting co-infection. But even that, the 6% or 7%, is way lower than what we usually see with something like the flu, with co-infection and superinfection rates up to 50% in some cases in the ICU. Next, please. So what can we expect when we talk about superinfection or co-infection and antibiotic use? We need to remember now we have some information from the data I just shared with you that it is there, it is not that common, it is commoner in the ICU setting. So if we see a patient who wasn't hospitalized before, they are coming with mild symptoms of COVID, or even the more severe ones before in the first 48 hours of admission, they are usually coming because of the virus. We expect superinfections and nosocomial infections in these patients after 48, 72 hours of hospitalization. We need to remember that the critically ill minority of the hospitalized patient, especially if they have risk factors for nosocomial infections, are at higher risk of co-infection and superinfection, especially elderly patients with underlying medical problems, on a ventilator, or prolonged hospital or ICU stay. And most importantly now, since steroid use is part of the cornerstone of the treatment, we are seeing more co-infections, especially fungal infections, with the steroid use. So when do you need to start antibiotics when we see somebody with COVID-19? If we think that the patient is presented with typical findings of the COVID-19, it's reasonable to hold off starting antibiotics. We can start empirical treatment if we think about lobar consolidation being caused by a bacterial pneumonia, or other findings on chest imaging suggestive of bacterial pneumonia. We can start empirical therapy directed towards the most likely pathogen, dependent on the local antibiograms and the geographical distribution. The sooner the better. Antibiotics save life. There is a lot of data showing that if we delay antibiotic introduction or start beyond 1 hour, that carries increased mortality for patients, especially with severe sepsis or septic shock. We need to do some testing as part of the workup, obviously. So we don't wait for the test results. We just do all the cultures that we need. We send all the samples for microbiology that we could do, depending on what's available in our hospital. And after that, we start the empirical therapy. We reassess, we reevaluate daily basis, sometimes even less than that. With the new molecular data, the results come back faster, and assess the need for the antibiotic and see if we need to continue, adjust, or stop. We have some inflammatory markers like a PCT, procalcitonin, or CRP, but unfortunately some of those may not differentiate COVID from bacterial infection on their own. They should be part of the decision making with the other criteria that we just mentioned. We talk about COVID, and this slide I'm not going to spend a lot of time on, but we change a lot of things we do. Like in infectious disease clinic, we do a lot of telehealth visits now, where we do virtual visits. Patients don't want to come to the hospital because they are afraid they might get infected. The hospitals don't have enough staff to accommodate the surge of patients if somebody got exposed. So there's a lot of diversity now in the way we are offering care. You offer patients virtual versus physical visit. And if they use virtual, some studies show that that is correlating with increased antibiotic, just because patients obviously with COVID will have fevers, and most of the time providers will be tempted to start antibiotics. And obviously if you're doing virtual visit, like you are limited on physical exam, you are limited on microbiology data. So there's a lot of emphasis on trying to stop using a lot of antibiotics and try to see patients virtually and try to get the ones that need to be seen in the hospital to the hospital to optimize their care.
Yes, Prof. Absolutely. And it is definitely a growing problem. And of course, that the COVID-19 situation makes it a bit harder. Now, following or in the shadow of the World Antimicrobial Awareness Week, I just want to bring to the audience attention that there was a stakeholders meeting in May 2020 between the United Nations, the World Organization for Animal Health, and the Food and Agriculture Organization. They wanted to actually expand the scope of the World Antimicrobial Awareness from antibiotics to antimicrobials. And I mean, for the audience that maybe they're not really expert in the subject, there's a difference. Like antibiotics, they only target bacteria, while antimicrobials, they're actually broad to bacteria, viruses, and fungi. So the question here to Prof. Sharman is, I mean, the slogan for this year is antimicrobials handle with care. That brings me to the question, Prof, what is the current treatment for a COVID patient? And is there actually resistance to these antimicrobials that are targeting the COVID virus?
Okay, this is a good question. So for the COVID-19 approved antiviruses, there's a lot of debate lately. If a lot of you, I think, heard about the WHO study looking at remdesivir versus placebo for COVID patients. And unfortunately, in that study, it did not show actual benefit for many of the patients enrolled. There's other studies from the US showed some improvement in decreased length of the hospitalization or decreased length of the symptoms. So because of this, the standard of care, honestly, what we are seeing in real practice is the standard of care where we handle patients' oxygenation, like electrolyte imbalances, and the dexamethasone is the one that we are seeing making real difference in patients' outcomes. Just recently, the convalescent plasma study came out, and it wasn't very robust, and there's a trend now in the US to stop using convalescent for a lot of patients. And there is some experimental treatment with monoclonal antibodies and JAK inhibitors and all these other things, but they should not be used outside of a clinical study. So the remdesivir is the only thing that we have in our repertoire in the US, in addition to the standard of care. We use it for 5 days, sometimes longer if we think the patient is improving on it. But we need more data to see if there is actual benefit of this antiviral compared to just the standard of care. The resistant, I think, is something that needs to be looked at down the line with the use. We know that we have some issues with the resistant. It's not a big deal, but it is there with the influenza virus. So the HIV virus, the CMV virus have resistance to antivirals. So it will be important for us to see if COVID-19 resistance is going to be an issue down the line.
Yes, absolutely, Prof. Thank you for sharing that with us. And just for our audience, if you have any questions, please drop it in the comment box below, and our speakers will be more than happy to answer it, especially during the Q&A session at the end of this talk. So speaking of COVID-19, I just want to ask Dr. Ghulam, from a microbiology point of view, I mean, for the general public, some people that are comparing the COVID-19 with the influenza. I'm talking about the virus itself. So can you just tell us briefly what are actually the main differences between the coronavirus, the novel coronavirus, and actually the related virus to it, which is like, for example, the flu virus, from a microbiology point of view?
Well, yeah, it has been escalated at the beginning of February, and then that people would say, well, we're just talking that this isn't flu, this is flu infections, this is flu disease, and the truth is this is unknown virus. I mean, to answer your question, I mean, in terms of microbiology, it is really an unknown virus. So when you compare the virus to any well-known viruses now, even though that there is many publication has been published recently, and there is a full genomic study has been revealed about the genomic sequences of the virus, but mainly, as I said, it's unknown. However, both of them, if we compare like coronavirus to respiratory viruses like influenza, they are both causing infection in respiratory infections. However, there's many things, and I think I'm gonna mention some of the differences from the perspective of microbiology. I would like if Dr. Sherman will touch base on the some of the clinical features of some of the symptoms. But the transmission rate, for example, of the coronavirus, it has been shown that it's highly infectious comparing with influenza virus. As you can see, influenza virus can cause infection or can transmit or spread to one or two people, like comparing with coronavirus that has been recently found that it's one can transmit to 6 people. So you can see how much this is different. I mean, I'm not going to go to answer the question at the genomic level, but I'm trying to give some clues that that our audience could give this information. The other one is that in terms of diagnosis, I mean, basically both of them, we are doing PCR. So it's like qPCR, real-time PCR. We are targeting certain sequences that is particularly specific to each virus. The other things is that coronavirus with the symptoms, Dr. Schumann might like to have some input here, but I know that the coronavirus has more tremendous symptoms like the difficulties of breathing and so on. The other one is that there's very crucial one that the influenza, for example, could cause infection to the kids and those below 10 years old, and likewise the old people. However, the coronavirus has shown that it's not really affecting those young generations like kids and babies. In terms of, as I said, term of diagnosis I already mentioned. This is mainly the main differences in terms of viruses and the microbiology background. I know Dr. Sherman would like to add some points right here.
Yes, perhaps Prof can add from a clinical point of view.
Basically, it is difficult since we are approaching the flu season here in North America. Usually October is the time when we give vaccines for the flu. We are trying to educate everybody about some of the differences because obviously in the last 9-10 months, everybody is only hearing about the COVID. The flu is one of the most important viral infections that we see every year. It causes 60-70 million cases of the flu or influenza-like illness every year in the United States. It has like significant morbidity and mortality. The common symptoms are pretty much similar, but exaggerated more for some things in COVID. One of the things that we see in COVID that we don't see in the flu is the loss of taste and smell, and it's kind of pathognomonic now for the COVID-19 in like early differentiation before even doing the PCR. You both can cause fevers up to like high fevers, headaches, coughing more common with the COVID, especially the dry cough. The fatigue is more pronounced with the COVID. Something very peculiar, but it's also seen to a lesser extent in the influenza population, which is the asymptomatic carrier or the mild symptoms. And I think that's the focus on a lot of research now to identify why some people get very limited or no symptoms compared to somebody who has full-blown cytokine storm ending up in the ICU on a ventilator.
Yes, exactly. Well said, Prof. So I think time will tell. With more research being conducted, with more patients are being treated, I think clinicians and scientists will have more clear guide actually in order to distinctly distinguish between both COVID and influenza. But like you mentioned, Prof, these are signs and symptoms that can help clinicians in the diagnosis. Back to you, Prof, on the last part of your presentation, which is on antibiotic stewardship.
Yes, so as Dr. just mentioned, antimicrobial stewardship, entails viruses, fungi, as well as the antibiotic. We are trying to tackle the unnecessary excessive antibiotic use in patients focusing on the COVID-19 pandemic. When we talk about optimizing antibiotic use, we are trying to optimize the outcomes clinically, but trying to decrease the collateral damage of the antibiotic use. Its toxicity, especially if you're using combinations, sometimes that can carry nephrotoxicity, kidney toxicity, can carry neurotoxicity. Some of those medications that we give, especially the broad spectrum antibiotic, can select certain pathogens like candida overgrowth, can select for emergence of resistance. And we need to remember that should be combined with infection prevention because it's important to identify resistance in the healthcare settings. And it's important that we do the appropriate contact precautions for the patients so we will not have an outbreak in like an ICU settings or in a cancer ward or something like that. So because of this, antimicrobial management has been bundled in something called antibiotic stewardship. And in that, there's so many different facets. You can start with something like what we do now, which is education. You can develop guidelines and clinical pathways for your hospital. You can do those optimization charts and tell people about what kind of dosage they need to use for different antibiotic. Try to educate about IV to PO switch every time you have a patient with a functional GI tract and you have a good antibiotic with good bioavailability. Obviously, trying to avoid giving IV with the risk of IV-related infection is important. You can do prospective audits, and that's something that we do on daily basis, review all the positive cultures in the hospitals, focusing on high-risk areas, trying to see if there's any mismatch between bug and drug. So when we talk about the COVID stewardship, we need to remember that even if we started empirical antibiotics, we need to review the need for that antibiotic once we have some diagnosis, whether it's the PCR saying this is COVID, you don't need antibiotic, or the blood culture, the sputum culture, whatever culture we send, telling us that it's unlikely that the patient has a coinfection. And it's important that we only start these, as we mentioned, in somebody where coinfection is likely, especially in patients in ICU on a ventilator, suspected nosocomial infections, all these high-risk patients. We need to start narrowing down the spectrum once we have the culture resulted, as we just showed in the graph. It's important that you use the narrowest spectrum antibiotic for the pathogen identified because You don't want something with an anaerobic activity if you don't have an anaerobic infection. You don't have something that covers Pseudomonas, that if there's no Pseudomonas infection, because that's how resistance can develop. It is important to remember that now with the newer modalities in treating COVID, especially somebody with a cytokine release syndrome or somebody with symptoms mimicking bacterial sepsis, is empirical that we need to cover them for antimicrobials until we have more information, and that's where rapid diagnostic is important. And we need to review the need for these antibiotics, especially in somebody who's in immunomodulatory treatment, steroids, or one of those newer monoclonal antibodies that can lower somebody's immunity and make them more susceptible for infection. And the shorter the better for the antibiotic. I'm going to show a slide discussing this. So the JAK and all these other treatments for and risk for co-infection, there is like gap knowledge need for further studies, but most patients who are on these are unfortunately more immunocompromised and at higher risk of bacterial as well as fungal infections. We need more studies to show co-infection in ICU patients. Especially, we see some reports about fungal co-infection, which we are not covering in this, but we are seeing some mold co-infection, especially in elderly patients with comorbidities, especially diabetes. So it's important to identify that. And one important point, and I think that was a problem worldwide, is lack of resources initially and shortages of protective personal equipments, PPEs. There was no enough gowns, gloves in a lot of hospitals, and those were directed towards COVID care. And because of that, most hospitals had increase in their co-infection because of the cross-transmission or cross-contamination between healthcare workers and patients because of improper use of the PPEs. So the shorter is better. This is the new wave in infection control and infectious disease and treatment with antibiotics. The classical 14 days and more treatment for a lot of infection is being challenged with randomized controlled studies. And fortunately, every 2-3 months, we have a newer study showing something in this effect, where they compare the shorter duration of antibiotic compared to the longer one. And fortunately, they have equal outcomes, whether it's pneumonia, whether it's community acquired or hospital acquired, whether it's complicated pneumonia, like urine infection, complicated intra-abdominal infections, even gram-negative bacteremia, 7 days, treatment was as effective as 14 days in a randomized control study. So always think about stopping antibiotics shorter than what we used to do before, because you are not going to jeopardize the patient. You are saving the collateral damage from the extensive use of the antibiotic, the cost of the extensive use of the antibiotic, and trying to save that antibiotic for the next person needing that. So when we talk about resistance with antimicrobials related to the COVID, as we mentioned challenges in the beginning, there is some opportunities here because a lot of hospitals are getting extra funding to combat the COVID. Some of that extra funding can be geared towards antimicrobial resistance surveillance, hiring more people, optimizing software, like building microbiology labs, focusing on stewardship programs and the priorities, developing rapid diagnostic. This is very important, not only in COVID, but for any infection. If the faster you know what the patient has, the better. There should be some global incentives for pharmaceutical company, money given directly to them to support new anti-infective agents. Collaboration, something like what we do now worldwide, about like expertise and methods to improve global resistance and sharing like what worked and what not. I think this is very important. So when we talk about outcomes, it's not only giving a patient a medication. We need to choose the right drug for the right patient in the right dose, in the right duration, focusing on the bugs MIC, overcoming the patient's kidney function, liver function, allergies, So it is a big process between starting the antibiotic and getting to the clinical cure, and that's where antimicrobial and antibiotic stewardship is very important in guidelines development and pathway development, in addition to identifying bug and drug mismatch. One last slide, I think, before we finish, is the importance of the molecular diagnostics, and I think this is going to be discussed in our next part of the talk with Dr. Ghulam. This study from Arkansas that introduced a new molecular test for blood cultures showed that just with its use compared to the conventional blood culture that was used before, it decreased the length of stay, it decreased the time for optimal therapy, and it decreased the duration of antibiotic treatment, because if you have a contaminant from the get-go, they will stop the vancomycin or they will stop the antibiotic that was on board. So just this small slide can describe how important it is to have rapid diagnostics and the importance of investing in that, because you can save length of stay, can save directly on the antibiotic course from stopping it earlier, and optimizing antibiotics for patients needing special antibiotic from the get-go because of resistant genes that the bacteria has. So in conclusion, we just described that the rate of bacterial co-infection, fortunately so far, is still low in different studies, but it is higher in ICU patients with comorbidities. We need to be on the lookout for those. All hospitals and healthcare systems should adopt an active antimicrobial stewardship program, especially focusing on COVID, since this is the new problem now, trying to ensure appropriate prescribing habits by doctors, trying to decrease the collateral damage of antibiotics, especially creation of more resistance, like what we showed in that study from New York, or co-infection with bacterial, whether it's candida or mold. There is a big role, I think, in early detection with the rapid molecular diagnostics, as we'll hear in the next presentation. And something that Dr. Saad said at the beginning, it's everybody's job to preventing the increase of antimicrobial resistance. And thank you for your attention.
Thank you very much, Professor Mann, for your insightful presentation. Yes, definitely in the midst of the COVID-19 pandemic and the shortage of new antibiotics in the pipeline, I think antibiotic stewardship is definitely one of the most effective ways for us to preserve what we have of antibiotics actually now. And I think Professor Mann said it clear that there are so many ways actually to tackle this issue, and stewardship is definitely on top of the list. Now, this will bring us to our second speaker, Dr. Ghulam Dab'an, and he will be talking about antimicrobial resistance from another perspective, from a more microbiological perspective and diagnostic perspective, how it has actually been detected and how it can be identified, especially with the use of latest technology. Dr. Ghulam?
Yeah, thank you very much, and let me thank Dr. Prof. Sherman for this very informative presentation. And I'll be talking about these antimicrobial resistance. We'll talk about the diagnostic procedures. Just want to remind ourselves and the audience that it's 11 something, and I think we should go sleep before. Just joking. Because here in Canada, it's
yes, I know.
Yeah, just trying to make a break.
Yes.
Yeah. So yeah, if you just go to the next slide, please. Yes, thank you very much. So I'll be talking about. I'll try to make it a little bit shorter because I know I can see that Dr. Sherman already talk about antibiotic resistant threats, just one slide, and then antibiotic susceptibility testing assays. I think this is the second component that is important in my slides. And then we'll go to the strategies of decreasing antibiotic resistance. And then finally, we'll be talking about the global preclinical antibacterial pipeline. So as you can see here, the antibiotic in 1928, penicillin, first discovered by Alexander Fleming. And then Chain and Fleury helped to develop penicillin into the widely available medical products. In 1943, drug companies began mass production of penicillin, and 1 year later, the U.S. military takes penicillin to the battlefield. And for year one, it's just like 1 year later, both Fleming, Chain, and Fleury awarded the Nobel Prize for Physiology and Medicine. And then after Second World War, many more antibiotics were developed. And today we're about, we have like 150 types. So now, as I said in the last sentence, we have 150 antibiotics, but unfortunately, we're losing a lot of them, as Dr. Sherman explained these things in details. So I would like to categorize this antibiotic eras to 3 eras, and it's not my opinion; it's many scientists' opinion. So we before these antibiotics came to the market or to the clinical use, the world was living in the era called pre-antibiotic era, where a very simple infection was killing people. And then with the discoveries of antibiotics and the coming pipeline, we had the era called the golden epic era, where we used to have this medical miracle drugs, the antibiotics. So all these procedures, surgery, transplantations, a lot of complicated clinical procedures were successfully achieved by the availability of antibiotics. So unfortunately, as we just talked today, that we are almost like losing a lot of it. And if we really lose these antibiotics, and I think we are heading toward the post-antibiotic era, where common infection will no longer have a cure, and once again, the bacterial infection will kill unabated. Let me explain a little bit here. As Dr. Sherman also he showed us a graph in different perspective, but this is a very scary graph that we can look at the antibiotics when we have had the antibiotics at the beginning, as I said, like 1928, production 43, 44. And then as you can see right here in 1985 to 88, we have like a lot of antibiotics in the market. But with the time passing, you can see these antibiotics and this arrow, the black arrow, is going down, decreasing very rapidly, and within the same time, the antibiotic resistance is increasing consistently. So as you can see, right, in 2009, 2010, 2013 until now, we're having no antibiotics. And Dr. Sherman showed us that we only have 2 antibiotics in 2015, 2008 and 2010. And it's a really scary graph for antibiotics. Next slide, please. Yeah. In this slide, it's a really nice to look at the perspective of antibiotic history in terms of like a general term, what happened in the world. So as you can see right here, in 28, the discovery anti-penicillin. 43, there was, as we said, the production, and then the penicillin resistant was 48. You can just imagine from 43 to 48, we have like about 4 years only to find a resistant to this newly discovered antibiotic. And if you can see right here, for example, we have a methicillin antibiotic are like inverted to combat this penicillin resistant staphylococcus. However, we got some resistance like a few years later. So as you can see here, I don't want to go in details with this graph, but as you can see here, we are in a race for antibiotics, treating infection, finding antibiotics, and then just 1 year later, two years later, there's bacteria that developing resistance. So this is like a race, like a racing game. It's really concerning in the era of antibiotics. Next slide, please. So I'm not gonna spend some time here, but as you can see right here, we have in 2017 we have diflufloxacin antibiotic was like it's a synthesized one, and then just 2 years later the bacteria like develop resistant to this antibiotics. I don't want to go to these details of years, but it's the same story that I have explained in the previous slide, and also Dr. Schumann explained in details with different antibiotics. Now, the problem with this phenomena is that the death attributed to the antimicrobial resistance every year, it's like very concerning. As you can see here, compared to the other major causes diseases, like before a decade or even with this time that we used to know cancer causing a lot of death, and it's up to 8.2 million in 2050. But experts and scientists are like expecting that the antibiotic resistant will cause much more death comparing with any diseases in 2050. It could reach to 10 million. In fact, nowadays, 700,000 death due to antimicrobial resistance. This is really crazy. And if you compare even, I mean, yesterday I was like looking to the newly published articles, and one of the very reputable scientists said that, I'm not exaggerating to say, the concern from antibiotic resistant is really much more than COVID-19. Because as you can see here, COVID-19, I mean, I'm not here to compare, but COVID-19, there's a lot of attention toward this crisis, reporting and everything. But as you can see with antimicrobial resistance, it's not reported from every country. It's not systematically reported. We don't know everything there. But however, you can see 700,000 deaths in 1 year from these diseases and from these infections, and we are going further without any antibiotics. Next. So generally, the causes of antibiotic resistance could come from over-prescribing of antibiotics. Dr. Mahmoud has spoken a lot of this. And patient not finishing their treatment. This is well-known phenomena in the very developing countries. And overuse of antibiotics in livestock and agriculture. Also, the poor infection control in hospitals. Lack of hygiene and poor sanitations. Lack of new antibiotics being developed. So these points is very important to understand why we have antibiotic resistance. Well, this is comic slides that this is like showing you this is a senior bacterial, the bacteria that is resistant to antibiotics, and this is the way how antibiotic resistant genes or chromosomes or whatever transmissible elements is transmitted from the senior bacteria to others. So this is the senior bacteria saying that, hey kid, want to be a multi-drug resistant? Stick some of this into your genome. Even colistin will not be able to harm you. So this is what's happening, but this is in a comical way. Next, please. Yeah. The report that has been released by CDC United States about antibiotic resistant threats 2019, they categorized the microorganisms, particularly bacterial bacterial infections resistant to antibiotics to different categories based on their resistant to antibiotics, casualties, death. So we have like 3 categories. The first one is urgent threats, which consisted of different bacteria. I can mention carbapenem-resistant bacteria, carbapenem-resistant Acinetobacter, carbapenem-resistant Enterobacteriaceae. The second category is serious threat, including different species of microbes. I can mention this ESPL producing Enterobacteriaceae. The third category is concerning threats, which include erythromycin-resistant group A Streptococcus, clindamycin-resistant group beta B Streptococcus. So this is based on the recent classification, and CDC estimates that 2 million people in US become ill due to antibiotic-resistant infection. At least 23,000 people die as a result of antibiotic-resistant infections. 20 billion in direct excess healthcare cost. Can you imagine that? 35 billion in lost productivity. At least 50% of antibiotic prescribed for people are not needed to, or not even prescribed correctly. This is I mean, this is really tremendous. You're talking about United States. You can imagine what's happening in other countries.
Exactly, Dr. Ghulam. This is a very important point that, I mean, the misuse of antibiotics has accelerated the emergence of AMR. And yes, I mean, United States, I mean, North America, Europe, I mean, these are the countries that, of course, the healthcare system and the infrastructure is monitored. But the problem is that with other parts of the world that are facing different types of crisis, political crisis, economical crisis, there are wars here and there. So the level or the reporting of AMR resistance is almost not seen actually due to conflicts. So I mean, what are your comments on that?
Well, as you said, it could be infrastructure. Like one of the things is that infrastructure, countries is not equal in their hospital systematic reporting, tracing antibiotic resistance service. I mean, healthcare service, including diagnosis. I mean, there's many bacterial infections that are not diagnosed well. I mean, if you are not making the proper diagnosis, then you're not talking about even antibiotic resistance. Besides, as you mentioned, and there's a lot of conflict in many different countries. I believe one of the very important things to tackle this problem is to have a systematic online system connecting the world together. I mean, you see, for example, these websites like World Meter, even they are not hospital-wise, but such system will help these countries to every time update their data. But to do that, you need support. You need financial support. And who's going to do that? Most probably WHO could do something in this. So this is complicated. I mean, you can't imagine this is going to happen easy, like just simple.
Yeah. So I think, Dr. Sherman, you've worked, I mean, in the Middle East and many parts of the world, and you've been exposed to different healthcare systems. So, I mean, from your experience, from your point of view, such database like the one that Dr. Ghulam is talking about, is it really possible in the near future to tackle the differences in the healthcare systems around the world?
Yes, this is an important question. The problem is, and I think Ghulam touched base on, is the funding. Some hospitals in the periphery in some of the countries, they don't even have means to do simple microbiological detection. So it's very difficult for these areas to have an antibiogram and share their resistant patterns with others. It has to be from like the network from a country where they have resources in each area. They have like a referral lab where they do more molecular testing, more bacterial cultures, more rapid identification. Like you need a place in every area where appropriate or correct antimicrobial resistance is identified, then shared to help the end users, the healthcare providers on the best antibiotics. I worked overseas in different university settings and specialist hospitals where resources were there, and it was as good as it is in the like Europe and in North America. But at the same time, I was like doing a lot of inspection. Like I used to be an inspector for the infection control for different hospitals where you see lacking simple infection control and microbiology tools that they will help identify resistance. So
Yes,
this, I
exactly.
think,
So these are the differences that actually
I think, Saad, you have technical problem.
yeah, he is muted.
No. Well, he's gone. he's not even muted now.
If the moderator is still on, maybe you can start your second part.
Oh yeah, sure. Yeah, thank you. Okay.
yes.
Yes.
Yes. So yes, you're right, Professor Rahman. These are the differences between the healthcare systems around the world. It makes it a bit more difficult. So I mean, let's hope a more systematic way will be developed in the future. Back to you, Dr. Ghulam.
Yeah, thank you. So here in this slide, we will talk about the mechanisms of antibiotic resistance. So in this slide, I'm going to spend a little bit of time here to explain the antibiotic resistant mechanism at the molecular level. So I'm having an example of gram-negative bacteria right here, and how much. I mean, look, for me, as a microbiologist, I always look to these creatures, the small, tiny microorganisms, and how smart are they? So look at the mechanism of antibiotic resistance, for example. These bacteria has the ability to do something very unusual, to just defend. It's kind of immune system, sophisticated one. Many different mechanisms. One of them for the bacteria to defy or resist antibiotics. One of them is to lose porins. These porins is like channels. It's channels in the outer membrane through the preplasmic structure, and then for the antibiotic to enter the bacterial cell. But the bacteria is doing some modification for these structures, so the antibiotic wouldn't be able to penetrate or to enter through these channels. So this is one of the mechanisms. The other one is that the bacteria is able to produce enzymes, and this is one of the very most common antibiotic resistant mechanisms, like beta-lactamases and many different classes of beta-lactams antibiotics. So the bacteria is producing enzymes. The enzymes is able to destroy or having a catalytic activity to modify these antibiotics. One of the other mechanism is called the over expression of efflux pump expression. So the bacteria has something called to pump out molecules of the antibiotics. Let's say that the antibiotic was able to enter the cells and pass through the porins or any other mechanism in the outer membrane, but then the bacteria will use the efflux pump and they will pump these antibiotics outside of the cell. One of the other mechanism is that producing an enzymes that is able to modify the target site of the antibiotics, and in this case, like aminoglycosides antibiotics. Also, the bacteria is able to mutate the targets in the genomic level, like the DNA level. So this is one of the examples for quinolones antibiotics. One of the other mechanisms also is that we know that the ribosome is the factory of producing proteins for bacteria. And some of the antibiotics are targeting these ribosomes. Once it has been targeted, then the bacteria will not be able to produce protein and then will be killed. However, these bacteria is able to do mutations and modifications to these ribosomes, particularly for the sites that have the affinity of binding with the antibiotics. Therefore, these antibiotics would not be effective anymore, like tetracycline. Now, one of the other also mechanisms, it's kind of smart one, it is the bypass target. So the bacteria has a pathway of metabolism, and then one of the protein of enzyme that normally used in this pathway is the target for antibiotics. So the bacteria will bypass that protein or that enzyme. I mean, typically will not use it, or will alternatively use another enzyme, which is not the target of antibiotics. In this case, the bacteria will avoid the antibiotic. The last one that I can mention right here is that the mutation in particular site, and this is example for polymyxin, because polymyxin is targeting the lipopolysaccharide structure in the bacterial outer membrane. And this is one of the mechanisms that the bacteria is avoiding or defending itself from antibiotics. So these are mainly the most common mechanism of antibiotic resistance in gram-negative bacteria. Next, please. So generally, how does antibiotic resistance develop? We know now the mechanism at the molecular level. But normally or generally, how these resistant like these phenotypes develop. So at the beginning of primary infection, somebody is coming to the hospital with a primary infection. It will be taken after diagnosis, and proper diagnosis will be taking antibiotics. And in this case, if the antibiotic is the wrong antibiotics, or in case that the patient didn't comply very well with taking these antibiotics or poor compliance, this will lead to generate different like bacteria that is resistant to that antibiotics. In addition, some of the bacteria will be killed likely. However, there will be some certain bacteria, could be a little amount of the bacteria that has been killed, will be survived in the patient. So in the second infection, or the sometime later after some period of time, there will be like another infection. So we know that there is some bacteria that has been already developed resistant, and it's existed in this patient. The doctors, physicians will give another antibiotic. Most probably, even the first antibiotic will not be effective, so they will give another second antibiotic, maybe combination of antibiotics, and we will be having two scenarios. Either those antibiotics will be potential to kill this bacteria, and this is the patient will be lucky enough to be cured, or the other scenario, which we, or the doctors and physicians, are encountering right now in this era, that bacterial infection is not treated with any antibiotics. Even you put combination of antibiotics, you have like pan-drug resistant bacteria, which is resistant to all available antibiotics, and this will lead to death. So this is how we know how's the resistance develop and the consequences of that. Now, I want to touch base about this one because this is one of the very most potential like transmission procedures or transmission way of the bacteria, how they are spreading their antibiotic resistant genes. We know that antibiotic resistant genes are existed or encoded by chromosomal or the bacterial DNA in the chromosomal level. However, there is many antibiotics nowadays has been found that they are encoded by plasmid or mobile genetic elements, which include plasmids or transposons or phages. So the phages that surviving in the bacteria. So these mobile genetic elements compose the most threat of antibiotic resistant transmission for humanity, for us, because it's easy way and it's very effective. And the bacteria, and it has been found recently that bacteria in different species could transmit the antibiotic resistant genes to different species, not from the same species. This is kind of very alarming, and this is one of the way how the plasmid or the mobile genetic elements could transmit from one bacteria to other by 3 procedures. One of them is transduction, where the resistant genes could be transferred from one germ to another through bacteriophages. The second way is by conjugation, where the resistant genes can be transferred between germs when they are connected by pillae, 6 pillae. The third one is the transformation. Resistant genes released from nearby living or dead even germ or bacteria that can be picked up directly from another germs. So these mechanisms, although they are not comprehensive for all other mechanisms of resistance, but this is very effective and potential of spreading antibiotic resistant genes among bacterial species. So I know Dr. Shuman has talked about this one. How can we stop antibiotic resistance? Or he talked about the strategies. I'm gonna just mention them quickly. So we need to improve labs. So and one of the questions that Dr. Saad asked, how we can tackle this problem. So improving our labs, diagnosis, and talking about the identification of bacteria, and then doing the antibiotic susceptibility testing in a proper way and a rapid way will be more potential helping us to tackle this problem. Collecting and sharing data, we talked about this one when we answered the last question, and then using antibiotic wisely. I think Dr. Mahmoud already have spoken about this one, how in the antimicrobial stewardship, using antibiotics, talking about taking measures to prevent infections, that is very potential in the way of stopping antibiotic resistance. Well, in this slide, we will have more information about the current methods of identification, and then therefore doing the antibiotic susceptibility testing. So what is going on nowadays in the labs over the world, most probably in the developed countries and even developing countries? Clinicians and hospitals, physicians are relying on the current methods, which is the mostly phenotypic procedures, which is starting from the identification of the causative agent, and then once having a pure colony, then going forward to do the antibiotic susceptibility testing. Either they are using manual testing, conventional procedures, or they are using rapid. So here I need to explain a little bit about the procedure step by step. So when we have the samples, there will be like a gram staining, and then there will be more culturing or cultivation on a plate. And then when you have a pure colony, most probably this is a traditional procedure. However, if you, nowadays we have fully automation platform like MultiTOF, and also using the nucleic acid amplification testing, immunodiagnostics, and we have the fluorescent in situ hybridization. Those procedures are more they're not really quick, but they are more fully automated, and they can process many samples together. And then you can, after that, when you have the identification, you will do the antibiotic susceptibility testing, whether you can use the disk diffusion testing, which is the manual called Kirby-Bauer procedure, or the broth dilution or microdilution testing. Now, the problem is, the only problem with these testing is that, as you can see here, this procedure will take you about 36 to 72 hours, sometimes more. It depends on the organism, the clinical case. And here, if we connect this one to the problem we are encountering in our time with COVID-19, you need, as we are talking about secondary infections, Dr. Mahmoud was explaining about this is secondary infection or not, so he was talking about identification and so on. So here we are. If we have a rapid identification procedure that has standardized and validated and passed the quality control, then we will be able to decide whether this COVID-19 hospitalized patient has infection, secondary infection, is this bacterial infection or not? And then therefore we can do the susceptibility testing, and this will help us to follow the judicial choosing of antibiotics or using antibiotics. So as you can see here, this is the most common procedures available in the labs right here. However, nowadays we have, for example, in our hospitals and in many different hospitals, we are using the molecular assays. So nowadays there is a commercial kit that is specific for resistant genes, certain resistant genes. You're talking about, for example, beta-lactams. You're talking about different beta-lactams genes, and then you just need to do the same procedure when you are talking about pure culture. So you need to spend that time, which is about 24, could be 48 hours, to have the pure colony, and then you go for amplification using a PCR. This will take about 2 hours or maybe 1 hour now, and this will reduce the time to 3 or 24 to 30 hours. But however, it's still long, as you can see right here. This is not really, this is just particularly for polymicrobial samples, and this is just will yield to a preliminary diagnosis. So we are relying on this one, P section. If we are able to find assay or molecular assay to do the identification directly without cultivation and incubation, that will be the hit. So the second slide will explain to us a little bit about the conventional procedure of AST. If you would like, Saad, to next, please. So I may explain about this one in the previous slide, but however, we have like this AST testing, which is the antibiotic susceptibility testing. As I said, both microdilution or disk diffusion. Now there's new technology of microfluidic and digital microscope. However, it needs to be standardized and passing a lot of quality control. But as you can see here, we are about 24 to 48 hours. Next slide, please, Saad. So we are relying now on the molecular assays. As you can see here, whether you are relying on enzymatic or nucleic acid or mass spectrometry, yes, you will have your results. Most probably, you will do the identification within 2 hours to 3 hours maximum. You just need to have the specific primers for the to do the identification. However, when you have like a blood culture or you have like polymicrobial infection, you need to know where is it. You need to run like universal primers and so on. But at the end, you will end up in something called when you are running also the antimicrobial susceptibility testing using the molecular assay, designing a primer, having a primer specific for certain genes. Now the problem is we are having a problem with the molecular assays that, for example, in the nucleic acid, genes do not always relate to phenotypic resistance. I mean, sometimes you can detect the gene that's available there in the bacteria, but sometimes the bacteria is not reflecting that resistance in a plate. So this is one of the very concerning or things that make you not really until now. Laboratories, microbiology laboratories are relying on the phenotypic assays. I mean, when they're doing the susceptibility testing, although they are using platforms like Vitec, for example, but nucleic acid is still for certain gene resistance. The other problem now, as I mentioned before, with the conventional procedures, it's slow. I mean, we need a rapid antibiotic susceptibility testing. That one is taking about 24 hours with the identification, 48 hours. This is one of the problem that the market or the scientists or the medical institutions are trying to find some procedure that could tackle this time. I mean, and go with the standard procedure that is comparable to the phenotypic assays. Next, please. Yeah. So I didn't go in details in the antibiotic susceptibility testing. I could go further, but I wanted to make it like more in general. Now I would like to have an exposure or an idea about what we have in the pipeline. Now, we talked in my presentation, Dr. Sherman presentation, that we are lacking antibiotics. So what is the solution? Recently, what has been known and published that we have some, let me see, strategies, some antibacterial pipelines in the way. So they are categorized mainly to 6 to 7 pipelines. Now the scientists and medical institutions are relying on developing direct-acting small molecules. These small molecules could be antibiotics, and those are 70% are new molecules to be developed. There's approximately 20% of them. They are old molecules, and the target for these things is 50% gram-negative. 8% of the pipelines will be dedicated for potentiators. These including beta-lactamase or efflux pump inhibitors. It's pretty much the same thing we have right now. And they are trying also to expand the spectrum of the current antibiotics. Trying also to enhance or restore activities of antibiotics that has been not effective recently. 4% of the pipeline will be like repurposing drugs. 40% will be antibodies and vaccines, and this is one of the very potential research. 3% about trying to develop immunomodulators. 8% will be antivirulence. So this is also a very promising one to target the bacterial, whether enzymes, toxins, virulence factors, so you can disarm the bacteria without placing any life-threatening pressure on the bacteria, avoiding the bacteria from developing resistant. 30%, which is recently has been really promising, screening or producing bacteriophages. Bacteriophages, scientists, or even some of the scientists, are believing now bacteriophages could replace the problem of antibiotics, the lack of antibiotics. One of the story that we may remember, one of the American doctor that when she went a trip to Egypt, and then her husband was infected with Acinetobacter baumannii, and they came back and they found that this is a very multi-drug resistant bacteria. In fact, it was band-drug resistant to all antibiotics. And then the man was about to be loosened, and the wife went to the institution in the US that they are developing bacteriophages, and they started this, and then they administered the bacteriophages to the infected person. And then gradually he was recovered. And this is one of very, very successful stories of bacteriophages. Next, please. So the strategy of decreasing antibiotic resistance could be therapy. As Dr. Mahmoud said, use narrow-spectrum agents. Do not use antibiotics. This is for clinicians, mainly for non-infection related purposes. Treating infections only when this is improved patient outcome overall. Restrict the last line of antibiotics. When in terms of prophylaxis, use short courses. I mean, single dose is usually sufficient for surgeries, given the correct time also. prevention of infection, improve infection control hygiene, improve use of vaccines, improve infrastructure, safe water supply, better hospital design. And the education is very crucial here. That you need when you implement the strategy to tackle antibiotic resistance, you educate about the antibiotics to the medical staff, target both healthcare professional and general public. Surveillance is very important, and you need to know how much resistance is present, in which bacteria, and where, and what quantities are antibiotic used. Research also is very crucial, very tremendously needed. However, funding is the main point here. So we need new agents, we need new research, we need new and better vaccines as well. There's a lot of things could be developed, and it depends on the funding. Next, please. So I would like to conclude my slides with this quote that Sir Alexander Fleming said once a day, when he knew how much antibiotics is very crucial for life. And he said, the thoughtless person playing with penicillin treatment is morally responsible for the death of the man who succumbed to infection with the penicillin-resistant organism. He said, I hope this evil can be averted. So the question is, can we avert the post-antibiotic world and losing antibiotics? Thank you.
Well, let's hope the answer is yes, right? Thank you very much, Dr. Ghulam. So diagnostics and the diagnosis of AMR, especially in the COVID-19 era that we're living in, is very important. And I just want to highlight one important thing, that there is a recent study that showed hospital sewage water. They have found high levels of AMR genes in the hospital sewage water. Now, what does that mean? It means actually that there is an overprescription of antibiotics in the hospitals, and these antibiotics, the genes that are responsible for the resistance of these bacteria are actually finding their way into the sewer, and the sewer leads to the environment, and the environment is actually connected to animals and plants. And you see, this is the vicious cycle of AMR. Well, everything is actually connected together, and that brings us to the One Health approach, that we don't only have to focus on human health, but also animals and plants in the environment as well. So AMR affects everything. And for that, I would like to thank both our speakers, Professor Dr. Sharman, for his insightful talk, and Dr. Ghulam, my dear friend, for his insights on the diagnostic part. I just want to mention to our audience that please fill up the feedback form, complete the feedback form for our quality improvement. The feedback form can be found in the link below. I think we have one question from the audience that they want to ask us. A question from Zaid Al-Nouri. Are the fungal super or co-infection cases like the COVID-associated pulmonary aspergillosis mostly associated with steroid dose and duration of the hospitalized patients, or just the severity and duration of the illness in the ICU patients? Now, this is a very important, actually, question. Perhaps Professor Sharman will highlight that.
Yes, this is an important question, because we are starting to see more of this with the increasing number of cases. Obviously, the air quality of the hospital is important, because like if the patient is in the ICU for a long time and they get exposed to aspergillus, that this in the air around them. And that's where like having appropriate air filters, having appropriate infection prevention can decrease some of that. So for us, we're seeing more related to the immunosuppression from steroid use or other modalities that we are using for COVID. But I would imagine in other places, because of maybe lacking HEPA filters or certain controls in the environment to decrease the burden of the fungus, the mold in particular, the Aspergillus. Maybe they're seeing it just because their patients are staying longer in the ICU, in addition to being on steroids or immunosuppression.
Yes, exactly. Thank you very much, Prof, for that. And I think we have reached the end of our webinar. I say exactly 2 hours on point. Before we wrap it up, we would like to conclude our webinar, Professor Sherman, with any words?
Yes. Like as we talked about in the past 2 hours, antibiotics save lives. Our duty is to use them wisely, use them when the patient needs them, stop them when they don't, optimize the duration, optimize the dose, optimize the drug-drug interactions, hoping for the better outcome for our patients.
Absolutely. Well said, Professor Sherman. And my dear friend, Dr. Ghulam, any words to conclude the webinar?
Well, I believe in the diagnostic, doctors, proper diagnostic. And I wish we will be able in the research institution to come out with rapid molecular techniques that would tackle this very long time of identification of the infections and therefore the antibiotic accessibility testing. If we could come out with these technologies, I mean, I can just imagine the tremendous development that new technologies that could help us a lot to implement these things in our hospital settings in terms of diagnosis. And I would like to say thank you to everyone. I'm very happy to be with you guys, Dr. Sherman, Dr. Saad. It's a wonderful opportunity.
Yes. Thank you very much for both speakers. And that concludes our webinar. And again, our webinar is actually in conjunction with the World Antibiotic Awareness Week. This year's slogan for 2020 is Antimicrobials Handle with Care, and with the theme, basically, that is United to Preserve Antimicrobials. Let us all be there. Stay safe, everyone, and thank you again for our speakers. God bless. Thank you very much.
Thank you.